Hello and welcome to ID Talk, Answers from Infectious Disease Experts. I'm Dr. Nathan Price, a pediatric infectious diseases specialist at Banner University Medical Center, Tucson, and associate professor of pediatrics at the University of Arizona College of Medicine. With Dr. Scott Olson, I am the Arizona AAP Infectious Disease and Immunization Co-Medical Director. This podcast has been created to answer questions from our chapter members about anything and everything infectious disease and immunization related. Thank you for tuning in today. This is the week of March 17, 2025. So let's get started. Our first question is, with the Advisory Committee on Immunization Practices, ACIP, meeting being postponed, what could this mean for new vaccine recommendations? This is a fantastic question, and quite frankly, I don't have the answer to it. The ACIP regularly meets to discuss many different aspects of many different vaccines. They look at data on vaccines that are in development, they look at new vaccines that have already been approved, and they look at vaccines that are already in production. They evaluate, reevaluate, and regularly make recommendations about all these different vaccines. They were scheduled to meet last month and really had a very full agenda. They were going to look at influenza vaccine data and also data about chikungunya, RSV, HPV, meningococcus, and many other vaccines. With the new administration, the ACIP meeting has been postponed with no rescheduled date determined. Now, related to the question about new vaccine recommendations, the FDA did recently meet and they recommended to the vaccine producers which strains of the influenza virus to include in the 2025-2026 seasonal influenza vaccine. They did review a lot of data, but they did not have ACIP input like in years past, and it's unclear what kind of data they had from the WHO since there's now a lack of collaboration with them as well. So it really is a concerning time for children's health. Without ACIP, we really lack a major part of determining safety, efficacy, and how vaccines should be used. I'm really hoping that best case scenario will be that this is just a temporary setback, but we'll have to see what happens in the future. All right, let's go on to the next question. The number of foodborne illnesses is on the rise in the U.S. Can you review the 3 most common foodborne illnesses, including their signs, symptoms, and treatment? Another really good question. Foodborne illnesses really are quite common, and they're usually transmitted by the fecal-oral route. Most of these illnesses are self-limiting, but in the right situation, they can become life-threatening. For most of these things, prevention is really your best bet. Doing things like having good hand hygiene, making sure you're cooking your food appropriately, not preparing food for others while you're sick with a GI illness, following safe food preparation and storage practices all can go a long way in breaking the chain of transmission. So there's various lists out there looking at how common these illnesses are. But for the most part, the common ones are norovirus, non-typhoidal salmonella infection, and disease caused by Clostridium perfringens. So let's talk specifically about these different organisms. Norovirus is a virus that is very hardy. It can survive on surfaces for weeks, and so you can imagine it's really easy for it to infect people. This is the virus that goes through close quarters like cruise ships and daycares, and I'm pretty sure several years ago every member of my family got it at Christmas time. The incubation period is quite short, 1 to 2 days, and symptoms usually include vomiting and profuse watery diarrhea. Some people will have systemic symptoms like myalgias and fevers. Symptoms usually are self-limiting, lasting 1 to 3 days, and most people do fine with it, but in some high-risk populations you can have severe disease and very occasionally death. To make the diagnosis, you can do a stool PCR, but this often isn't necessary because, again, it's a self-limiting disease. Treatment is with supportive care with oral rehydration, or if you're not able to tolerate PO, you can always use IV rehydration as needed. In severely immune-compromised patients who have more severe disease that's not improving, you can consider treatment with nitazoxanide and or oral immune globulin. Next on the list is non-typhoidal salmonella. We won't talk about typhoidal salmonella because the question was about disease in the U.S., and typhoidal salmonella really tends to be acquired when traveling abroad. So salmonella is a gram-negative bacteria. We tend to think about it with chickens and chicken eggs. And people think about the cracks in the eggshells and how the bacteria can enter there. But interestingly, the bacteria can actually live in the chicken's ovaries and can be inside the egg and have nothing to do with cracks on the shell. But it's not just eggs and chickens that have problems with salmonella. It can get into a lot of different foods through cross-contamination of equipment that is being used to process these foods. And then workers can have infection and have poor hand hygiene and can also contaminate foods. So we can see infections and outbreaks related to different meats, but also fruits and vegetables. It can even get into flour and baby formula. Your best bet is prevention again. And so things like hand hygiene, not mixing things that are used to prepare different types of foods. For example, not using knives and cutting boards for raw meat and then using those same knives and cutting boards for things like fruits and vegetables that aren't going to be cooked. Also, not preparing food while you have a GI illness will go a long way to not sharing that GI illness with people, and that certainly applies to salmonella. So people that tend to get salmonella disease tend to have diarrhea. It can be watery or bloody. It can be high or low volume. You may or may not have fever, and extraintestinal symptoms are rare, but they can happen. And so you can see things like bacteremia, osteomyelitis, and meningitis in the right situation. And this tends to affect immune-compromised people and people who are asplenic, but rarely can happen to immune-competent people as well. The diagnosis is usually made by doing a PCR test of the stool, but you can also use culture, although most labs are going away from cultures because of the ease of using PCRs. In most cases of isolated gastrointestinal disease, the disease is self-limiting and antibiotics aren't needed. And that's because giving antibiotics in that situation doesn't usually improve outcomes and can increase the risk of developing a carrier state. Antibiotic therapy is recommended in certain situations. Of course, if you have extraintestinal disease, but if you have isolated gastrointestinal disease, you can treat in children who are under the age of 3 months, children who have chronic GI diseases, children who have hemoglobinopathies, or other immune-compromising conditions. Antibiotic resistance is increasing worldwide, and generally we treat with ceftriaxone or azithromycin until we otherwise have susceptibilities back. So last on our list of common infections is Clostridium perfringens. This is a gram-positive anaerobic bacteria that produces spores and a toxin. So you're probably familiar with this bacteria. When it gets into tissues, it can cause gas gangrene. But when ingested, it causes a very different disease, which is usually self-limiting. So the bacteria produces a spore that's heat resistant. The toxin that it produces is not heat resistant. So what usually happens is you have food that has the spore in it, it gets heated, and it doesn't kill the bacteria. So then if the food is left out to cool for a long time and not refrigerated, then the bacteria can start producing the toxin. If you were to reheat that food properly, then you'd be okay because that heat would destroy the toxin. But if you eat the food without reheating it, then you ingest the toxin, and it's the toxin that produces the disease. So because you're ingesting a toxin and you're not ingesting a bacteria, you don't have an incubation period like you would generally think with a bacteria or a virus. The toxin's already there, and once the toxin gets to its source, it starts causing the disease. So toxin-mediated diseases like with Clostridium happen really quite quickly after the person's eaten the affected food. So instead of happening a couple of days later, within hours of ingesting the affected food, the toxin goes to work and you start having abdominal cramping and diarrhea. You don't tend to have vomiting, which is different than if you were to have toxin-mediated disease from Bacillus cereus. You can do special testing looking for the toxin in the stool, but usually it's not necessary because usually the disease goes away within about a day or so, and there isn't any treatment for it other than supportive care with rehydration as needed. Like most GI toxin-mediated diseases, you want to avoid antimotility agents. There have been cases of necrotizing colitis associated with the toxin in someone who took an antimotility agent. Okay, let's go to the next question. Question 3. Can you speak about the relationship between vitamin A and measles? How do you combat misinformation that vitamin A treats measles? Another really great question. Measles are on the rise, and as I speak, Texas is up to 279 cases in their outbreak, and nearby New Mexico and Oklahoma have cases as well. In Texas, a child who was otherwise healthy died from the measles, and this is the first death that we've had in over 10 years in the United States. This is really unfortunate for many reasons, but especially because this is completely preventable. Measles is incredibly contagious, and it has a greater than 90% attack rate. So basically, if you are non-immune and you're near somebody with the measles, you're going to get infected. And you don't have to be close to that person. This is an airborne transmission-mediated disease. The droplet nuclei can stay suspended for many hours, and there are cases of people who got the disease and their only risk factor were that they were in the same building as somebody who had an infection. We know that the vaccine is very effective. Single dose is 93% effective in preventing infection, and 2 doses increases that by a few more percentage points up to 97% efficacy. It's important to note that that second dose isn't a booster. You either responded to the first one or you didn't, and so they give that second dose to, again, increase the efficacy of that vaccine. Of course, the other way to get measles immunity is to get measles disease, but we know that is really a terrible option. We know that out of every 1,000 people who get measles disease, up to 3 of them will die. 1 of them will get encephalitis. We know that 1 in 20 will get pneumonia, and that 1 in 4 will require hospitalization for severe symptoms. We know that prior to widespread measles vaccine use, 15,000 to 60,000 people every year would have ocular disease because of the measles that led to blindness. And in areas of the world today where there is poor availability of the measles vaccine, measles is still a major cause of blindness worldwide. The WHO has estimated that over the last 24 years, measles vaccine has saved 60 million lives. So this is not a benign disease and is not something you want to get if you don't absolutely have to. The other interesting thing is that measles disease decreases your immunity to other infections. We know that the measles disease can decrease B cells, T cells, and cell-mediated immunity. Your antibody levels will drop after getting the measles, and data show that child mortality increases after measles infection. And the thought is that these children are getting infected with things that they used to be immune to because they either were vaccinated or had the disease, and now because their immunity is depressed because of measles infection, now they are no longer able to fight off the infection and are dying. So many reasons not to get measles infection. So how does vitamin A factor into all of this? We know that vitamin A is an essential vitamin, meaning that our body needs it, can't produce it, and has to be obtained through diet. Vitamin A is important to the immune system, and we know that vitamin A can enhance immunoglobulin and lymphocyte levels. It's also needed for various tissues like the cornea. It's been long recognized that people with vitamin A deficiency have more severe outcomes with things like xerophthalmia ophthalmia, leading to blindness. We also know that if you supplement vitamin A in those situations, you improve outcomes with ocular disease. And that's ocular disease irrespective of measles infection. So in a lot of the world, there's vitamin A deficiency. And we know that if a child with vitamin A deficiency gets the measles, there's increased risk of mortality and ocular disease and blindness. We also know that measles infection can decrease blood levels of vitamin A. So knowing that has long been a practice of supplementing with high-dose vitamin A during measles infection. And the goal is to improve outcomes with ocular disease and to improve mortality. Now, the true benefit of that is unclear. It does really seem like there is a major benefit when it comes to ocular disease, but when you look at other outcomes with regards to measles and vitamin A, the data isn't as clear. For example, a Cochrane review did not show improved outcomes of mortality when using vitamin A supplementation. They also didn't show improved outcomes with pneumonia. There may have been some benefit when it comes to otitis media. The upside is that supplementation with vitamin A has a low risk of serious side effects. So because of all of this, the WHO recommends that any child with measles disease gets supplementation with vitamin A, and that is irrespective of what country you are in when you have the infection, including the US. So vitamin A supplementation may be beneficial in mitigating some of the risks of measles disease, but there's really no evidence that it improves the major things that we're worried about, like meningitis, encephalitis, death, pneumonia, those sorts of things. And there's no evidence to say that it prevents disease. So it's really important that we combat this misinformation that vitamin A is somehow this wonderful cure-all when it comes to the measles. It really does very little in the grand scheme of things when you look at measles and the severity and what can happen to children. Yes, it may have its place, but again, we need to really be focusing on the prevention aspect of things because that's where we're going to have the most benefit. Okay, last question. With spring break coming up, are there any recommendations to prevent the spread of infectious diseases while traveling with children? Great question, and traveling is always difficult, and especially traveling with children has its own set of problems that come along. This is certainly a fun time of year. For some folks, they've already had their spring break, but we're also coming into the summertime, and that's a lot of time that people get together with friends and family and go try out new things. And of course, as you're going and doing different things and getting together with different people, comes in the risk of getting infections from those things and people as well. I think the best answer to this question are to do the things that we all know and recommend, and also, of course, use some common sense. So, of course, our patients need to be up to date on vaccines, because anytime you get together, you may have the exposure to a vaccine-preventable disease. And one vaccine to think about specifically, of course, is the measles, like we've been talking about. And it's important to remember that children aged 6 to 12 months can get measles vaccine. It just won't count towards their 2-dose series. And this is important if someone is going to be traveling outside the U.S., because measles is endemic in a lot of places still. The last case of the measles that I saw was in an infant who was 10 months old when he left the U.S. to go to Asia for a few months, and of course he picked up the measles on the way back. Unfortunately, his mother didn't know that he could have received a measles vaccine before he left. If you're traveling internationally, the CDC has a really nice travel website that you can go to look at, and they have recommendations and discussion about what diseases you could potentially interact with, and they give recommendations for things to do to prevent infection in those areas. And that includes things about mosquito avoidance, malaria prophylaxis, and different vaccines that are available for different people as needed. And of course, there are travel clinics that specialize in this. Many of them see children as well. And so I highly recommend that you discuss with an expert if you have a patient that's going to be traveling internationally. So in addition to those things, it's the usual things, right? The practice hand hygiene. Our family recently went to a theme park, and my wife and children were a lot better at practicing hand hygiene than I did after the rides, and I was the one that got sick on the trip. And that's a little bit embarrassing considering I am an infectious disease doctor and I'm talking to you about how to prevent infections while you travel right now. You can still think about using masks in the right situation if that's what works for you or for your patients, and especially if you have higher risk and you're in congregant settings. And while you're traveling, think about how you are preparing and storing food, because that can be a source of infection as well, as we just talked about. This is especially important if you're traveling internationally because, again, they may have problems with their water supply and have an increased risk of fecal-oral transmission of various infections. So pay attention to things about where your water is coming from if you're on one of those trips, and things like ice cubes or things like fruits that you can't peel because those may have come in contact with water that's contaminated. And be especially cautious of street vendors who may not have access to good hand hygiene because, again, they can contaminate the food, and that's a classic situation where people get infected with these infections. All right, that about does it for this episode of ID Talk. Thank you again for listening. Arizona AAP members can submit questions for future episodes to id@azaap.org. Arizona AAP would like to acknowledge the generous support of the podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to infectious disease and immunizations in Arizona, or to become a member, please visit azaap.org. Thank you for all that you do. We'll see you next time at the next ID Talk podcast.